Good morning, everyone, and welcome to our weekly TIRO multidisciplinary seminar program. Before I get started, I just want to make a quick comment regarding this session that we conducted, I believe, a week ago with Julianne Sosa, who gave an update on the 2025 ATA clinical practice guidelines. Many people have been requesting the opportunity to view that video, and unfortunately, due to the American Thyroid Association's request and insistence, we were not able to post that on the website in light of the fact that the guidelines have not been published yet. So we apologize for that. It is certainly a deviation from our what we usually will do, but this was a very special circumstance. Well, I am really thrilled this morning to introduce our presenters on a topic that I think will be extremely important to all of our listeners and also to the general public. It's a pleasure to introduce Dr. David Toro Tobon, who's an assistant professor, a Mayo Clinic scholar, and an investigator at the Care and AI Laboratory in the Division of Endocrinology at Mayo Clinic. Having completed his endocrinology fellowship at Mayo Clinic, he is currently pursuing a master's degree in artificial intelligence, and in particular, its use in healthcare at the Mayo Clinic Graduate School of Biomedical Sciences. His major focus is in applying AI to enhance the assessment and treatment of thyroid disease and to improve healthcare delivery. I'm very much looking forward to this discussion and the work that he's done on GLP-1 receptor agonists and the concern related to its possible role in thyroid cancer. We're joined this morning by Dr. Jeffrey Mechanick as our discussants. He is both a friend and colleague who's professor of medicine at the Icahn School of Medicine at Mount Sinai in New York. Dr. Mechanick holds many titles and also holds the record for the most number of letters after his name of any physician or actually any professional that I know. This was not listed. They're not listed here, but there would not be any room on the rest of this slide if we put all of those letters after them. He is the director of metabolic support in the Division of Endocrinology, Diabetes, and Bone Disease. He has enjoyed an extraordinary academic career with 460 publications, 118 chapters, and 12 books. He is past president of the American Association of Clinical Endocrinology, as well as the American College of Endocrinology. And I'm doing an injustice to all of his accomplishments, but if I were to go through them, we would fill up the hour without getting to the topic in hand here. So with that, I'd like to turn over the program to Dr. Toro Tobon, but would like to just acknowledge for those of you who have enjoyed our TIRO podcast, Voices of Wisdom. They are released on a monthly basis, and really would recommend that if you want to get a really great in-depth look at a particular topic, I strongly encourage you to listen to these. So David, the platform is yours.
Good morning, everyone, and thank you so much for having me. I've been here a couple of times now, and it's always a pleasure to be back, so thanks for having me. The topic today, I think, is very timely. We're going to be talking about GLP-1 receptor agonists and their relationship to thyroid cancer. This is a narrative review that was conducted by a couple of my colleagues and close collaborators, as you can see on the screen. I do have to warn you, even though they did most of the work for me, I did introduce a little bit of my own personal views and analysis into the slides I'm going to share with you today. And I'm looking forward to a good discussion at the end. My goal is that by the end of today's session, we all have the tools to critically analyze all of this breadth of information that is available out there, and that we have the tools to understand where do we stand, what is it that we're missing, and how do we navigate this landscape with our patients? How do we actually deal with these when we're um, talking to our patients? So how did we get here? I think the problem is we are dealing with a game changer, which is called GLP-1s. In diabetes, we know they improve glycemic control. They are great for cardiovascular risk reduction, for weight management, for renal protection. And because of that, the FDA has expanded their use, and the American Diabetes Associated has expanded their use. And in general, in diabetes care, their use has expanded progressively over the last decade. Now, additionally, the use has increased for weight management. And this has probably the one that has sparked a little bit more progressively over the last couple of years. I would say probably last 5 years. One of the added benefits is that it has shown that there's not only weight reduction, but there's also improvement in complications such as hepatic steatosis. And the weight reduction, it's probably similar with some agents to what would be achieved with surgical management. So there are pretty significant benefits of this pharmacologic therapy. Now, medications seem to be pretty good, but how many people are actually using these medications? If you take a look at just the US, the prevalence of type 2 diabetes is probably around 11% of the population. This is close to 28 million people. If you go and take a look at obesity, prevalence is close to 40%. This is close to 106 million people. So now we're talking, again, this is a gross overestimation because we don't know how many overlap and whatnot, but now you're talking close to 130 million people, so probably around 30%, 40% of the US population are technically candidates for these type of medications. How many are actually prescribed? If you take a look at this study that looked at prescriptions from 2015 to 2020, there were 65 million prescriptions. And year to year, the number of prescriptions increased between 10 to 30%. Now, keep in mind that this was until 2020. So in this, we're not accounting for the boom in prescriptions for weight management. So what you are not looking at here is that since this study was published, the increase in prescription for patients that are using GLP-1s for weight management without diabetes has increased over 700%. So what I'm trying to show here is that the amount of patients that are using these medications is incredibly large. The numbers are growing really fast. And not only that, but we are expecting it to grow even faster because there's more uses under investigation. There seems to be some potential benefit for metabolic liver disease, for neurodegenerative disorders, for heart failure, for peripheral vascular disease, for neuropsychiatric and substance use disorders, for hypertensions, um, and perhaps for other disorders. And this seems to be potentially independent of diabetes or even weight management. So we would expect that within the next years, the use of these agents is probably going to continue to grow. Why am I spending so many of my slides talking about this? Because if so many patients are using this medication that seems to be a game changer and seems to be a miracle, then the question is, are then GLP-1 receptor agonists safe? And if you go and look at social media, this is what so many influencers and so many people out there are trying to sell as the catch for people to see their videos. And this actually touches the core of what we thyroid specialists or thyroid enthusiasts or for what matter, any type of person that is prescribing a GLP-1 needs to know about these medications. Because when you go and take a look at the side effect profiles and the safety profiles, you're going to see that most of them are pretty on the safe side and even on the severity scale, they seem to be very mild, but there is a huge black box that touches our core. And this has been there since the approval of GLP-1s, especially, for example, this one we have on the screen is from Ozempic. It's a black box that says, we have preclinical data that shows that there is a risk of thyroid T cell tumors, um, of potential cancer of thyroid T cell tumors. So you probably should not be using these in patients that have history of medullary thyroid cancer or multiple endocrine neoplasia syndrome. So now we have a problem because we're saying we have this phenomenal medication that works for so many conditions that can potentially be used by so many people. But big warning, we have the potential of thyroid cancer. So we need to dissect what is really the evidence and is there really a risk that we should be worried about? And that's what the authors of the journal and what I'm going to try to help you dissect today here. It's what's the evidence behind these claims and how do we move forward? So the aim was to summarize what is the evidence and discuss implications for practice and clinical practice and research. What they did was a comprehensive narrative review. This was conducted between January 2000 and April 2023. This was done on PubMed and Scopus. The available evidence was classified into basic and translational research, observational clinical studies, randomized control trials, which was pretty much meta-analysis of randomized control trials, and pharmacovigilance studies. Understanding that each of these four categories have their pros and cons, so that's why they were grouped these ways. The meta-analyses were assessed for quality of evidence using the GRADE approach, and the observational studies were assessed for risk of bias using the Newcastle-Ottawa scale. So what do we have from basic and translational research, which is pretty much what sparked the first warning in the black box? I'm not going to bring you all the studies because we would need like 5 hours, probably more. But I did select a few that I think are important to show the results and kind of like go over what are the most important aspects. So this study was from 2010. And again, this is basic and translational research. So this was conducted in human and mice and rat cells. And what they did, what you're seeing here in the graphs, let me see if I can put the laser. So we have two graphs here. This one here was in rat cells, empty C cells, or C cells, and this one here was in human C cells, thyroid C cells. And what they are trying to measure here is how much calcitonin is released when these cells are stimulated by GLP-1, right? So what you're seeing here is that the C cells in the rats actually have an increase in calcitonin when they are stimulated by GLP-1 at increasing doses. So the more you stimulate them with GLP-1 receptor agonists, the more calcitonin they produce. That doesn't happen in the human C cells. So this is what sparked a little bit of that initial concern. They saw not only the C cells have the receptors, but they seem to be responsive to the stimulation of GLP-1 receptor agonists. And this was found to be the case for the rat C cells, but not the case for the human C cells. They also found that the C cells develop hyperplasia, especially when these patients were receiving the medication for a prolonged amount of time. So in the mice that received the medication for 9 weeks, in this case, liraglutide, 5 milligrams per kilogram daily, 7 out of 32 developed hyperplasia. And in the rodents that had a continuous infusion of exenatide, 0.25 milligrams per kilogram daily, 11 out of 36 developed hyperplasia. Now, there's two aspects that are important to keep in mind here. Yes, they develop the hyperplasia, but look at the doses. These doses are very, very, very high, much higher than the doses that we use normally in our patients. And the frequency of administration is also much, much higher. So this is an aspect of consideration. And the other thing is that there was some reversibility, at least with this kind of like short administration. Now, this was not necessarily the case when they took into consideration the patients that received the medication for 100 weeks or longer, or not the pace, and the cells that were exposed or the animals that were exposed to longer amount of weeks. But keep those two aspects in mind. And out of all of these experiments, two mice actually developed C-cell carcinoma with a 36-fold greater than human dose. So this is what we kind of like get from this study. Other findings that we got from basic and translational studies from 2011 and 2014, there's some PTC that was found in human samples, 18% and 32%. Again, the importance of it and the relevance of it, a little bit unclear. So what do these kind of preclinical studies and basic studies show us? GLP-1s are strongly linked to medullary thyroid cancer in rodents. That link is plausible, seems to be clear. Again, it's in rodents. But there's limited human data that suggests variable GLP-1 receptor expression in non-MTC cells. And the long-term carcinogenic risk is actually unclear. We don't really have clear evidence to suggest that. Also keep in mind the doses supremely high compared to what we use in humans. Now, what do observational studies show us? This was a cohort from 2019. This was a cohort and nested case control studies. Compared 33,000 exenatide patients versus 49,000 matched oral anti-diabetic agents. And there's going to be a couple of different comparisons here. This is all hazard ratios. And we have overall patients, more than 1 less than 2 years, more than 2 less than 3 years, more than 3 years. So we have different comparisons here. And this is the one for the hazard ratio. So as you can see here, we are not finding really that there is any significant difference in terms of cancer risk. Certainly, if you're seeing it up by year, all of these confidence intervals are crossing the 1. So by year is not making a difference. Here, you're very close to this threshold. So very, very difficult to say, even though they had this huge cohort for other type of conditions. Now, what is the challenge here? The overall incidence of thyroid cancer in this cohort was 0.16%. So it was exceedingly low. And when you have an incidence that is so low, even with these very high numbers, it might be that the study is just not powered to actually appropriately address this risk. So this is one of the challenges. And this study had actually used like 2 of the largest claims databases in the United States. So this talks a little bit about how challenging it is to actually assess the risk and the outcome of thyroid cancer risk based on claims and databases, which is what we have for most of these observational studies. That's why multiple studies have been done. This is not the only one. So we're seeing another one here from 2023. This one is a nested case control. This one is a little bit different because this one we started with patients that had already developed thyroid cancer, in this case, 2,256. And then these patients had been exposed to GLP-1 receptor agonists within the prior 6 years. They had exenatide, and they were evaluated with 45,000 match controls. And here, there's a bunch of different comparisons. We have those patients that were past users, current users, those that had less than 1 year of use, 1 to 3 years of use, more than 3 years of use. And here, there's going to be a couple of differences, I guess. So which ones showed some risk for cancer? We're seeing some increased risk of cancer in those that are current users. And this is the case both for all thyroid cancer, which is the light blue, and medullary thyroid cancer, which is the dark blue. And we're also showing that there is some increased risk of thyroid cancer in those that had 1 to 3 years, and this is the case for all thyroid cancer, and also for those that had medullary thyroid cancer. The risk also remained for those that had more than 3 years of use, but this was the case only for all thyroid cancer. When we did the analysis, or they did the analysis, for a medullary thyroid cancer, the risk was no longer there. Now, the estimates were way too large. So again, it might be that the sample was just not powered to appropriately assess the significance of this finding. So what are the general considerations and the summaries from these observational studies? Findings are mixed. If you see, it's not like all of them are telling you across the board, there's no risk or risk is increased. You're going to find some that tells you perhaps there's a little bit of an increased risk, perhaps there's not really a risk. What we are seeing is that the overall incidence and the absolute risk appears to be very low. There is moderate to high risk of bias in all of these studies. Part of the challenge is that since they rely on database claims, the way they build the cohorts is very variable. The way they define the outcomes, it's very variable. And this makes it very challenging to compare the outcomes of one study versus the other one. It's very difficult. You cannot really compare apples to pears. It's just not doable. There is high variability in the exposures. Some of them use single GLP-1 agents, some of them use different agents. The comparison groups are different. The timing of outcome evaluation is different. The elimination timing is different. Some of them enroll the patients at the time of prescription. Some of them enroll the patients 6 months after the prescription. Some of them did it 1 year after the prescription. So all of these are factors that affect the ascertainment of the outcome. There is no enough granularity in reporting histologies, phenotypes. So when you start doing these subgroup analysis and trying to understand how do the outcomes differ between all types of cancers and MTC or PTC or phenotypes or patient subgroups, how does this differ in younger patients versus older patients? We don't have that data. And part of the challenge is that this is just not reported on the database that are associated with claims. So we don't have that data. And since we don't have that data, it's very difficult to provide recommendations that are more fine-grained as opposed to what we have on the black box. And again, the retrospective nature of these studies makes things very complicated. There's residual confounding. There's an inability to establish clear causation. Now, what do we get from randomized controlled trials? This one is from 2023. These meta-analyses included or considered 64 GLP-1 receptor agonists randomized controlled trials, 26 of which have reported at least one thyroid cancer. Those are the ones that you're seeing on the screen. And what these randomized meta-analysis showed is that, or suggested, is that there was probably a slight increase in the risk of thyroid cancer. Um, but as you can see, there's a big asterisk because I think there's some caveats when you are going to analyze this information. Um, and it's that the statistical significance of this finding was lost when they did the random effect analysis. And the statistical significance was also not withheld in sensitivity analysis or in the difference subgroup analysis, including when they stratified the results by PTC and MTC. So this is challenging because, again, we have to remember that all of this started because we were concerned of medullary thyroid cancer. So we open a whole can of worms, and now we're not even able to fully prove that the original problem is linked, and we're trying to navigate if all types of thyroid cancer are an issue. So this makes that analysis a little challenging. There might be a signal, but there's not a strong, consistent risk that can be proven across the board. And I decided to include this one, even though it's a smaller meta-analysis, because this one including only patients with semaglutide, which is the one that most patients are using for weight loss in particular. So this one included two different analyses, one that is placebo control with 11 studies, and then one that was with active control with 16 studies. And this one actually was not able to identify any significantly increased risk. So what do these meta-analyses show us? Thyroid cancer has been infrequently reported in randomized controlled trials of GLP-1 receptor agonists, in which cancer was not the primary outcome. The absolute risk is low. Results suggest that thyroid cancer is a rare event, which makes imprecise assessment of the outcomes and the estimates. And there's no conclusive evidence of increased risk of thyroid cancer in GLP-1 receptor agonist users. And finally, and I won't spend too much on this one, the last category is pharmacovigilance. I only have one study here, and it's from 2021 from the European Pharmacovigilance Database. They reported up to 2020 of the 11,000 thyroid cancer-related events, 236 had involved GLP-1 receptor agonists, and not surprisingly, the proportional reporting ratio was much higher than any other medication. So it appears that it is more likely to report thyroid cancer related to these medications than to any other medications. That being said, remember, this is a voluntary kind of reporting, and there is increased awareness that there could be an association with thyroid cancer. So these type of studies do not really establish causation. So we cannot really make a lot of strong conclusions out of this other than, yes, there is a consistent signal that there's more reporting of thyroid cancer in patients being treated with GLP-1 receptor agonists compared to other agents. Now, I could not in good conscience go into future directions and give a space for discussion without briefly showing the results of our recent study, even though this was not included in the original journal paper, because I think it brings an additional component that was not present in the literature before. These studies from our group, including most of the authors from the original publication, and this was a secondary analysis of a trial emulation of a comparative effectiveness study. This study was done in 351,000 adult patients with type 2 diabetes. We compared GLP-1 receptor agonists versus other agents. The other groups included sulfonylureas, DPP-4 inhibitors, and SGLT2 inhibitors. And we did a series of analysis, but pretty much, and again, we could have another session just for this article, but pretty much what we concluded is that in the modified intention to treat analysis, we did not find any increased risk. We did find a slightly increased risk of cancer in the as treated analysis. This was very small. And just to bring to your attention, the incidence in our cohort of thyroid cancer was 0.17%, which has been pretty consistent with the other studies. Now, this is not the important finding I wanted to show you. This is not even the important finding. This is just to show you some preamble to that important finding. What you're seeing on the screen is the breakdown by year, the risk by year. So in the as-treated analysis, we saw that maybe there's a little bit of an increase, right? But what happens if we break it down by year? So if we break it down by year, it seems like in the intention to treat analysis, those patients less that have used the medication for less than 1 year maybe actually have an increased risk of having higher instances of thyroid cancer. And that was not the case for those with 1 to 2 years, more than 2 years, and it was not the case for those with as-treated analysis. So the question is, why are the patients that are having a medication for less than 1 year having higher instances of thyroid cancer when a medication should take a little bit longer to create a disease that usually is very slow progressing, unless we're talking about a type of cancer that is causing anaplastic cancer or like some type of cancer with like really bad outcomes, which doesn't seem to be the case. We don't have, again, hard evidence because we don't have histologies, phenotypes, and all this data, but doesn't seem to be the case. So we actually did another analysis, which I think is the nice piece of added literature here, and it's what is the difference in ultrasound utilization between these two groups. And this is the part that I wanted to share. What you're seeing here is 6 months and 12 months. And what we found is that the patients that are using GLP-1 receptor agonists, those in orange, are actually using ultrasounds much more frequently than those patients with other agents. And this is both at 6 months from initiation of the agents and at 12 months from initiation of the agents. This is the rate of utilization. So, and this was significant, again, at both times. So it could be that it's not that they're developing, it could be that we're just finding it because we know this is a highly prevalent disease, and maybe we're just happening to be more aware that there is a potential risk and there are more people concerned, and we are going and looking for it and finding a disease that was already there to begin with. So what are the knowledge gaps? If no causal relationship exists, why do some observational studies suggest an increased risk? Is it that we are capturing some confounders that are difficult to tackle with observational studies? Is it that we're dealing with increased case detection, which either way we probably should try to understand better so that we can tackle it better? Do we need to figure out a way to do larger studies in terms of numbers that are appropriately powered to assess thyroid cancer? Keep in mind that most of the like randomized controlled trials, for example, were not designed for thyroid cancer. They were designed for diabetes. They were designed for other outcomes, not for thyroid cancer. So they were not necessarily powered or designed to ascertain thyroid cancer as an outcome. So should we be doing adjustments in the way we measure thyroid cancer as an outcome? Should we having more robust analysis of thyroid cancer subtypes, more granular subgroups, sensitivity analysis, accounting for confounders, individual risk factors? Do we need to do more risk evaluation in diverse populations, younger individuals, those that are obese but non-diabetic, or those with prior history of non-medullary thyroid cancer, populations that so far have not been really included in the studies because we just don't have the data? So what do we do now with the information we have in our day-to-day practice? Among the general population, I would say the benefits likely outweigh the possible risks of thyroid cancer, particularly of that potential thyroid cancer that is likely going to be papillary and indolent in course. Among patients with family history of medullary thyroid cancer or MEN2A to B should not be used. There is no evidence to support a screening for thyroid nodules before initiating or during treatment with GLP-1 receptor agonist, and there is no evidence to consider GLP-1 receptor agonist as an independent risk factor for thyroid cancer. My take-home points: preclinical data in rodents suggest a plausible link between GLP-1 receptor agonist and medullary thyroid cancer, but this is not confirmed in humans, and the association with non-medullary thyroid cancer is less clear. Interpreting evidence from observational studies and clinical trial meta-analysis requires considering their limitations, and while thyroid cancers appear rare in GLP-1 receptor agonist users, the current data on increased risk or a causal link remains inconclusive. We need to weigh in the evidence and discuss potential risks and benefits with the patients. And definitely we need more research to address knowledge gaps, better characterize patient-specific thyroid cancer risk with GLP-1 use, and guide potential mitigation strategies. And with that, I open the space for questions, and I pass the baton to Dr. Mechanick.
Before, Jeff, before your comments here, I just want to encourage our audience to send in their questions, and I will do my best to get to them. But this is a unique opportunity to ask all the questions regarding these agents that that will be of help to you in your practice. Jeff?
Great, thanks. David, that was just a wonderful, thank you so much. Actually made it very clear for me. And Mark, thank you again for your kind introduction. It's always a pleasure hearing that. I have just a few points. I'll keep it brief because I'm sure there's going to be a lot of questions and answers. I want to provide some context for the discussion and the Q of A, and I have 5 points I want to go over. First, when we think about these GLP-1 receptor agonists, remember that they work so well and they're so popular because they have pleiotropic effects. So prior to the cardiovascular outcome trials, these drugs emerged really just as singular diabetes indications. But then with weight loss being observed and these emergent findings of cardiometabolic risk reduction, and then parsing that out and finding, as David said, it's more granular. We find that there's a renal protection, there's protection for mast cell metabolic dysfunction associated steatotic liver disease. And because of that pleiotropic benefit, intuitively, it would make sense that there's going to be a lot of other emergent, potentially adverse effects. For instance, you would think that on the basis of, there was a study by, I think, Zhang here I had, where there was some benefit on brain function, but we're also fearful because it's decreasing right food chatter, and that's one of the mechanisms of decreasing appetite, then maybe in the long term, there may be some cortical adverse effects and maybe contributing to dementia. That's another thing that's on the landscape. So the fact that neoplasm, malignancy, thyroid cancer, particularly spawned by the medullary observation in the murine model, it's not really a surprise. That's point one. Point two, we need to really understand what these drugs are for. I've spent a lot of time building these chronic models and merging together type 2 diabetes, obesity, cardiovascular disease, hypertension, lipid, residual risk with nutrition and inflammation, all bundled together in one chronic disease model. There's a lot of complexity here. And the GLP-1s with one particular drug and really just falling short only to lifestyle intervention, where you get a lot more impact on a networked integrative physiologic effect. These GLP-1s really have a potent effect. So for a patient at risk, you really need to be deliberate and diligent whenever you're considering not giving this drug, right? That's the context. The issue of this talk is, are you going to be so fearful of the risk for cancer, that you're going to deprive a patient who's failing lifestyle medicine, deprive a patient of a drug that really is going to work. Now, third point, as David really pointed out very well in that summary and conclusion and the take-home messages, and for the audience, I mean, that's really what should be burned in your mind, those points, which is overall, there's just not enough evidence to justify this fear and inaction. We don't want to commit errors of commission by ordering these unnecessary ultrasounds, not only at baseline, but with follow-up, calcitonin, et cetera. So ultimately, if it's not right now in 2025, if it's not so much a scientific question, really this is a practical question, a pragmatic question. How do we message this information to our patients who we're talking about GLP-1s? Dr. Erkin had asked me before, how many do I see a day? I'm, like many of you on the call, we're having discussions not only in continuing these medicines or dose escalations or hopefully de-escalations, but starting these drugs as a new agent in a patient's regimen. And we have to be prepared as healthcare professionals to engage in proper messaging that's based on the evidence and is fair. My next point is, what's the implication specifically? Well, it's the implication is this error of commission that, as a result of the temptation and maybe the patient pushing you, you do an ultrasound, you get false positives, up to 50% in some studies of ultrasounds are going to reveal some nodules. You'll pursue it. You may do an injudicious aspirate, get a Bethesda 3, maybe send someone to surgery, there's a scare, you get an incidental microscopic papillary. Now what you've done, not only has this burdened the healthcare system economically and burdened the patient emotionally and economically, but now you've deprived them of this vital medicine for their treatment. And indeed, the ramifications of diabetes, type 2 diabetes and obesity in the framework of primary and secondary prevention of cardiovascular disease, this is enormous. And this now brings me to my last point. I want to bring up a couple of sort of edgy things. What if, and this would really be, Mark, to you and to Ashok and the other surgeons on the call, what if you had a patient with an A1C of 13 or 14 or a BMI of 40, and you really needed to use this medicine, but there was some either reported history, documented history, maybe they truly had medullary in the past? Would you consider a total thyroidectomy? Now, before you jump and you say, well, that sounds really ridiculous, just do bariatric surgery, now you really need to compare apples and apples. What's a safer way to proceed here? Is it a total thyroidectomy, or would it be bariatric surgery to manage and enable the use of the GLP-1 in the total thyroidectomy patient, or not using the GLP-1 in the bariatric surgery patient? And I only bring this up as a thought experiment because these are the kinds of questions that we need to be prepared for. And the other issue I have for David, reading your resume, I'm intrigued. But this is a complicated issue, as everybody's thinking about this. It needs to be adjudicated, just like we had the problem with Avandia and non-fatal cardiac events that Nissen had brought up. It needed to be adjudicated. How does AI help us adjudicate these very complicated questions when we have not only research gaps, knowledge gaps, incomplete information, but we need to make a decision now. We need to have this adjudicated now because patients are coming in. So let me close out my remarks. Mark, I'll turn it back to you to moderate the Q&A.
Great. Well, thank you. Those are incredibly astute and really practical comments here. David, let me just turn this back to you and see if you have any comments before I put out my own surgeon-based questions for both of you.
Absolutely. Let me answer your last question, I guess, based on how can AI help us tackle this? And uh, truth is, when we are trying to assess issues that have such low absolute risk, we rely on observational and pragmatic studies because that's the only way we're going to be able to capture very large populations. The problem with these studies is that they rely heavily on insurance-based claims, and those are very low on granularity, right? Where I see AI helping us here is that information that was previously hidden on the EMRs that we couldn't use before. And the reason why we used to rely on insurance claims, um, we can now get it with AI. All of this data that was unstructured because of the pathology reports being so granular and not just a diagnostic code or a billing code. All of this information that is on the notes that we spend so much time writing down that was hidden because we couldn't pay an army of people to go and manually annotate 350,000 patients so that we could evaluate the prevalence or the incidence of a 0.17% thyroid cancer. We cannot do that with an army of people, but we can train a model that can go and look through the clinical notes, go and look through the pathology reports, and give us that information. It takes time, it takes resources, but it can be done accurately. So I think when one of the solutions that I see on artificial intelligence is how do we move from big data to smart data? We cannot longer rely on a diagnostic code because that is not giving me much information. But what if I can link that diagnostic code with the information that is just hidden there and sitting in the pathology report and that we can get? So that's where I see we can leverage that information, enrich all the data that is already there waiting for us to explore.
Great. Maybe Dr. Mechanick, if you could, you're seeing a large volume of patients on a weekly basis. What percentage, two-part question, what percentage raise the question de novo about thyroid cancer risk, and what percentage of patients who you deem to be candidates will you avoid the use because of this concern?
Right. So good questions. Actually, right now, I would say that a third to some days it's a half, or even the majority of patients, the conversation comes up about the GLP-1s and risk. And by the way, parenthetically, one thing we didn't say is, David alluded to it a little bit. A lot of the data you were looking at were not incorporating tirzepatide, and we have a whole pipeline of newer agents coming out that are far more potent, which have multiple incretin actions involved. So this problem is going to amplify moving forward. But getting back to the question, this comes up a lot, but surprisingly, the patients haven't yet dwelled on the thyroid cancer. They will generically ask whether it causes cancer. And again, let me just segue out again. Remember that these drugs are being used in patients with obesity, type 2 diabetes. Both of those conditions are associated with an increased risk of cancer. So not only epidemiologically, but mechanistically, by virtue of the insulin resistance, specificity crossover of insulin with IGF-1 receptors, and a lot of other mechanisms. So these patients are already at an increased risk in the population. But Mark, it doesn't come up that they're specifically asking about thyroid cancer or even medullary. Now, the second part is, how many have I held as a result of a concern? Well, as an endocrinologist, I follow patients with medullary thyroid cancer, and I tell them right off the bat, even if it's not on the horizon, that just be aware that these drugs are not going to be available to you. They're talked about so much in social media that almost every patient will be asking about it, even those, as we all know, with normal weight, just to drop some pounds. But this isn't really different from other situations. I recently had a patient who's had a history of severe pancreatitis in the past. And I remember writing the guidelines on this, although the pancreatitis issue was the same kind of thing, but we adjudicated it that it wasn't an absolute contraindication. But you need to really be a lot more diligent. Amylase and lipase are not really your markers. You got to examine them carefully, a lower threshold. But if they need it, and I've had patients who really need the drug, I start off much lower doses. I'm much more hesitant to escalate if I don't need to, but I've given it to patients with a history of pancreatitis. That's why I bring up this sort of rash kind of scenario with the total thyroidectomy. I don't want anybody here to think that that patients don't exist that must have this drug. There are patients out there with severe diabetes, hyperglycemia that's uncontrolled with lifestyle and current medicines, or severe obesity. And the GLP-1s really help prevent having to be in a situation to send them for bariatric surgery. I chaired the thing on bariatric surgery. It's a safe surgery. It's an effective surgery, but obviously if you can get by without it, that might be preferable. So the thinking mechanism is a little bit more complicated. You have to be able to message this to a patient in a very concise, clear way.
Great. Terrific. David, let me ask you, you gave us reference for GLP-1 receptors on medullary and non-medullary, or I think it was on papillary thyroid cancers. Do we ever see GLP-1 receptors on normal thyrocytes? Has that been looked at?
So that's a good question. And the data that we have has found mostly GLP-1s in C cells, mostly. However, there what I found in these preclinical data, and if anyone else in the call is here can correct me, is there is some incidental infrequent finding of GLP-1 receptors elsewhere. Now the question is whether they're active or inactive. It's a different story. It's my understanding.
Okay. And tell me, Dr. Mechanick, I hear what you're saying about pre initiation of GLP-1 and ultrasound and calcitonin. But if I'm in your office and I say I really would like to know, will you talk me out of getting an ultrasound and a calcitonin level?
No, I would do the ultrasound. I would put it in perspective. And, endocrinologists who have a lot of experience doing their own ultrasonography, and I know there are some on the call, we're able to tell. I mean, modern ultrasonography is pretty good at having an eye for something that's suspicious or not suspicious. And if that's what it takes for the patient to accept the medicine, if it's deemed to be medically necessary, then I'll do it. But remember, I'm not going to be subjecting the patient for aspirates willy-nilly. I'm not going to be subjecting the patient for ultrasounds down the line, for routine surveillance. So it would be on a case by case, because it does deviate from guidelines a little bit, but this is clinical judgment. And if this is what it takes, and this isn't unusual, right? There are a lot of patients who just through their reading, or they've had a personal history, they're cancer phobic because of other people who have had cancer in the family, and they just need to know. And I think you need to respect the individuality of each clinical encounter.
And you may have mentioned this, but will your threshold for doing a biopsy on a nodule, if the vary from guidelines in order to to reduce a patient's fears?
No, I won't deviate from guidelines. So once I decide to do the ultrasound, I have the TIRADS, thing right above my ultrasound machine, and nowadays it's really easy for the clinical decision making for aspirates. We're doing aspirates less and less, and particularly with the ability of modern ultrasonography to really give us an idea, gestalt, whether the lesion we're looking at can be observed or dispensed with, not followed up, or whether you need to act. But I think the real point of decision making is whether you do this not arbitrary, that's the wrong word, but this initial ultrasound based on a patient's fear. And look, this is the art of medicine. I talk people out of whole body imaging, right? There are a lot of patients who come in, they want whole body imaging. It's part of concierge medicine care across the country, and a lot of institutions offer it. The problem is false positives. David, this is where AI comes in. This is where AI is reading entire imaging, even though the imaging was ordered for a particular indication. So we're kind of on the cusp of the way a lot of this informatics from imaging is being processed nowadays. It requires a lot of human judgment. Whether 5 or 10 years from now, with more AI, there'll be less of a need for human judgment. That's for another discussion.
Great. Can I ask you, and again, this is a bit of surgeon ignorance. Are you committing a patient to lifetime GLP-1
Great.
once you start them?
Yeah, great question. So I actually do not, and I make it very clear when I speak with patients that I am not beholden to some of the recommendations and the consensus that patients must be on these drugs lifelong. It's not the situation like a statin where we rarely de-escalate. And just parenthetically, for those who know me, don't know me, I've written a lot. I'm very interested in lifestyle medicine. Part of lifestyle medicine is the paradigm of escalating non-pharmacologic care, lifestyle medicine. And baked into that is the deliberate de-escalation of pharmacologic care. So I will reassure patients that if they lose weight and they adopt better lifestyle, then we can de-escalate. It's no different than the randomized control studies showing that intensive lifestyle works just as well as monotherapy for stage 1 hypertension, or the diabetes prevention program, where 58% risk reduction with lifestyle compared to only 31% for metformin. So, big pharma may have us believe that you need to continue these drugs forever, but no, that's not the way I bake it in my particular practice. I'll try to leverage the lifestyle medicine part as much as possible and hopefully get them off, or at least de-escalate some of these medicines so it's the lowest amount of medicine possible. Hopefully that answers your question.
Yeah, great. David, can I ask you, do you have any, at 10,000 feet, do you have any other examples of pharmacologically induced neoplasia? And in particular, this may be an unfair question, what the usual lead time is on therapy before that risk starts to increase here? Is there any other, are there any other medications that you can think of where that we can draw analogies?
I can actually give you one that I think is very useful to keep in mind for thyroid cancer. So when you think about radiation exposure and you go by the guidelines from NIH, you're expecting to have thyroid cancer development after 2.5 years on average. So that's why when you think about GLP-1 receptors in thyroid cancer, and most of these studies showing increased risk in around 1 year, it doesn't fit the logic. It doesn't feed the logic.
Great. Terrific. We are up against the hour. I want to thank both David and Jeff for really outstanding discussions here. It's been incredibly informative. I want to invite folks back next week for the next TIRO weekly session. And I also would like to put in a quick plug for the World Congress of Thyroid Cancer scheduled for early July in Boston. And the program is really, truly outstanding. It will be a very intense 4-day program. And for those of you who have attended this Congress in the past, it is really an outstanding opportunity to see the latest information and get and be able to discuss with experts in the field. And with that, I thank everybody for joining and look forward to seeing you again next week.